Hello and welcome. My name is Asad Qureshi. I'm a resident at Temecula Valley Hospital, part of the UHS SoCal Medical Education Consortium. And today I'd like to share a case and present a little bit of knowledge for a sudden onset of a PLA2R positive membranous nephropathy associated with massive proteinuria and Anasarca. Membranous nephropathy is a glomerular disease with an incidence of about 1 in 100,000. It manifests as a nephrotic range proteinuria with peripheral edema, hypoalbuminemia, and hyperlipidemia. It's divided up into two categories, primary and secondary. About 80% are primary membranous nephropathy, of which 70 to 80% have circulating anti-PLA2R antibodies. These antibodies can assist with the differentiation of primary versus secondary membranous nephropathy, disease activity, progression, and response to immunosuppressive therapies. In this case, we have a 63-year-old female who presented to the ED with subacute onset of abdominal pain, swelling, and 10-pound weight gain within 2 weeks. Associated symptoms were nausea, vomiting times 2 episodes, and watery diarrhea times 1 episode. Past medical history includes hypertension, hyperlipidemia. She denied any social history or family history. Home medications were atorvastatin and metoprolol succinate. Vitals showed she was hypertensive at 188/92. Physical exam showed she was somnolent and mild distress, appeared nauseous while dry heaving, had diffuse swelling around her neck, diffuse abdominal tenderness with no rigidity or swelling, presented with Anasarca plus 4 pitting edema of the lower extremities. CBC was within normal limits. CMP showed a low albumin of 1.3 and total protein of 4.8. Urinalysis showed excess protein of 500 with moderate blood of 11 to 20 RBCs. ESR was mildly elevated at 57, TSH was 12.4, lipid panel showed a cholesterol of 281, triglyceride of 179, LDL of 193. EKG showed sinus bradycardia but was otherwise normal. Chest X-ray showed small bilateral pleural effusions with bibasilar atelectasis. CT abdomen pelvis without contrast showed mild ascites, Anasarca, pleural effusions, and a right renal calculus without hydronephrosis. Ultrasound of the lower extremity was negative for DVT. Hospital course, patient was immediately started on 40 milligrams of IV Lasix for fluid overload, along with hydrolysate and Imdur to help control her pressures. She responded well by producing 1 to 1.5 liters of urine per day. Urine creatinine to protein ratio showed an excess protein loss of 4.9 grams per day. She was diagnosed with nephrotic syndrome and started on lisinopril to help reduce glomerular pressure and decrease clearance of albumin. Full serological workup of secondary causes were negative. After resolution of patient's hypertensive urgency, CT-guided percutaneous core needle biopsy was performed in the lower pole of the left kidney. During patient's hospital course, she developed headaches, which resolved with Fioricet. She was started on Synthroid for subclinical hypothyroidism. Overall, her condition improved. She was discharged while pending pathology results. Final pathology results showed membranous nephropathy PLA2R positive. Light microscopy consisted of the renal cortex and medulla. The glomeruli showed diffuse global thickening of the glomerular capillary basement membrane and occasional subendothelial projections of the basement membrane spikes, along with intracapillary leukocytes. Indirect immunofluorescence staining of paraffin sections for PLA2R demonstrates diffuse segmental granular capillary wall staining. THS D71 was negative. In this case, we have a PLA2R positive membranous nephropathy of a patient with sudden onset diffuse Anasarca, hypertension, severe proteinuria, and hypoalbuminemia. Membranous nephropathy is divided up into two categories: primary, which is considered to be autoimmune, and secondary, which is due to various causes such as malignancy, drugs, or lupus. Under primary membranous nephropathy, antibodies directly attack specific parts of the glomeruli. Immune complexes begin to form within the glomeruli and may build up between the layers, specifically between the basement membrane and the podocytes. Accumulation of these immune complexes activates the immune system, which triggers an inflammatory response, further damaging the glomeruli and exacerbating the proteinuria. Recent studies have shown that close to 70 to 80% of patients with primary membranous nephropathy have circulating anti-PLA2R antibodies in their serum. The anti-PLA2R antibodies attach to the phospholipase A2 receptors on the podocytes, which was responsible for producing the patient's clinical symptoms. Following are my sources. Thank you for listening.